is our endeavor, be it clinical, echocardiographic intervention. Our common interest is our patient. So without clinical background, without a proper application of the advanced devices, one of which echocardiogram, we can never serve the patient well. So with that kind of an approach, we are going to have this series of symposia. This is the first one of them. And would you please unmute your microphones, those of you who are not speaking at the moment, so that we can have a acoustic clarity. So while we were discussing about the curriculum of the program, we decided that we should have a look at the normal first before we go on to describe pathologies. So today we are going to have a look at the normal structure and function of the heart. I'm going to give a very short introduction on the, the total problem, how clinics can be integrated with echocardiography, and how it is important to have a quick clinical history and examination of the patient before we put our probe on the patient. So with me today, I have very long-standing 3 colleagues of mine. We have worked very closely in developing echocardiography in this part of the country. I have known them for at least 2 decades or even more, maybe 3 decades. And they are all veteran echocardiographers. They have performed numerous workshops at the local level, training programs, workshops, and also at the national level. So they are Dr. Rajesh Subra Ghosh, who is currently who heads the echocardiography department in the Ramakrishna Mission Seva Pratishthan. He is my colleague there. And he is also the Vice President of West Bengal Academy of Echocardiography. Then with me today is Dr. Dipankar Datta. He is one of the first echocardiographers in the city, closely following Dr. Shankar Mitra, Dr. A.K. Ghosh, and the third name that comes to our mind is Dr. Dipankar Datta. I mean, performing echocardiography at least for 3 decades easily. And he is currently the president of West Bengal Academy of Echocardiography, and he has been a past secretary, vice president of the organization also. And thirdly, I have Dr. Aniruddha De, who is again our close colleague at West Bengal Academy of Echocardiography. He has been a past honorary secretary of the organization, and now he's a very senior cardiologist and echocardiographer at the Apollo Gleneagles Hospital and many other prominent institutions. And he is a very well-known name on the national circuit. So I have a very eminent panel with me today to present this topic to you. So without much ado, I will make a very short presentation to start with, and then I'll pass the back to my colleagues here. So Tirthankar, can I have my slide set now?
Sure, sir.
So my topic is clinical relevance of echocardiographic quantification of cardiac chambers and function. Next slide, please. So I'll start with a clinical problem, how echocardiography can come to our rescue when we are confused about the particular problem in a given patient. A 63-year-old patient, diabetic, ex-smoker, presents with acute onset of shortness of breath at 4 a.m. in the morning to the emergency. He has been suffering from fever with productive cough for last 3 days and is a diagnosed case of old inferior wall myocardial infarction with a record of ejection fraction 43%. And he has also been known to be suffering from COPD. So he has been receiving aspirin, atorvastatin, ramipril, metoprolol, and of course, formoterol inhaler. So here you have a patient who has COPD with fever and productive cough, and he also has a background of old inferior MI. So this could be either a COPD exacerbation, could be a LVF in the background of a LRTI, or could be a mixed LVF and acute exacerbation of COPD. So we have to treat this patient, find out which is the most severe problem in this patient, and in this respect, echocardiography can be invaluable in a patient of this kind. Next slide, please. So patient will not come and tell us that I'm suffering from LVF. So he will come with dyspnea, and as you know, it can be cardiovascular and respiratory. So you are all very veteran clinicians. I'll not go into the details of this, but just to tell you that, I mean, you have to quickly diagnose a problem within 15 to 30 minutes and administer proper therapy before the problem gets out of hand and patient lands up on a ventilator. Next slide, please. So these are the causes of acute dyspnea. Again, I will not elaborate. Next slide, please. So this is the algorithm. I will not go into the details, but when the patient comes, first thing probably we do, and that has become very handy. It is available with every family now. We quickly have a look at the arterial oxygen saturation with the pulse oximeter. If it is abnormal, we quickly do a ABG, and then take a quick history and examination, try to find out whether we are dealing, have a quick look at the JVP and anasarca or pedal edema, quickly auscultate for any murmurs or third or fourth sound, and also auscultate the lungs. So if the diagnosis is evident, then it's fine. If you have, for example, one lung is silent, you know you are dealing with acute pneumothorax. If the JVP is grossly engorged and non-pulsatile and pressure is low, you know you could be dealing with a cardiac tamponade. But other than that, the next thing you do is a ECG and X-ray. And don't forget about the good old X-ray. It can be very handy. And that should be the automatic choice. So to introduce the importance of echocardiography in our day-to-day clinical practice. Next slide, please. So how can echocardiography help in the in further workout of a patient coming with breathlessness? The LA size and volume and LA pressure estimation is very, very important, and mainly by E by E prime ratio calculation and other features of LV diastolic dysfunction, which my subsequent speakers are going to highlight. Then we should have a quick look at the LV size and function, both systolic and diastolic. Don't forget about the diastolic function assessment. At the end of the day, we'd like to find out whether the patient has elevated LV and diastolic pressure. If there is no significant mitral stenosis, increased LA pressure means increased LVD, volume pressure, but there can be isolated right heart pressure also. Next slide, please. Tirthankar, next slide, please. Now, talking of chest pain and ischemic heart disease, this is the picture which is often cited by various presenters all over the globe. As you know, ischemia doesn't manifest in the ECG first. ECG comes very late. So echocardiography comes much ahead of that. And remember, diastolic dysfunction occurs ahead of systolic dysfunction. And of course, apart from overall systolic dysfunction, we should have a look at the regional wall motion abnormality. A visual 2D examination is of course okay, but these days we are also looking for regional wall strain imaging, which will tell us about very subtle wall motion abnormalities, which can give us a plethora of information about the coronary artery distribution of a given patient of coronary artery disease. Next slide, please. So this is how, no, I think you have skipped one slide, chest pain and echocardiography. Go back, yeah. So LV size and function is very important again with chest pain, regional wall motion and strain imaging. Then global LV systolic function assessment by LV ejection fraction, of course. But time has come when you cannot do with a global longitudinal strain. Diastolic function at rest, if it is normal, don't forget it to do it after a stress imaging, the diastolic function. And HOCM and aortic stenosis can also be causes of chest pain. Again, don't forget about the right side of the heart. Pulmonary stenosis, pulmonary hypertension can also give rise to chest pain. Next slide, please. These are the various causes of palpitation, any arrhythmias, atrial fibrillation, ventricular tachycardia, or volume overload situations. I will not go into the details of this in the interest of time. Next slide. And syncope. Don't forget again about HOCM, aortic stenosis. DCM can give rise to VT and syncope. Again, of course, ischemic heart disease, patient with past MI or acute ischemia can give rise to VT. And again, the right side of the heart, don't forget about ARVC and pulmonary arterial hypertension, which can also cause syncope. Next slide. Before I conclude, a few words about our preoccupation with ejection fraction, because I've seen for most of the primary level physicians, the echocardiography solely means to them what
कुमार सर आपका म्यूट हो गया है सर. डॉक्टर कुमार.
no firm relationship.
স্যার আপনারটা মিউট হয়ে গেছে.
Next slide, please. But at the same time, it remains very important because our classification of chronic heart failure is based on LVEF, HFrEF, heart failure with mid-range ejection fraction and heart failure with preserved ejection fraction. So for me, ejection fraction basically needs division into whether the ejection fraction is less than 40%, is it between 40 to 60%, is it more than 60%? Whether it is 63% or 67% doesn't really matter. Whether it is 37% or 34% really doesn't matter. I mean, that kind of variation can occur from echocardiographer to echocardiographer. It is really not critically important. And as I told you, LVEF is not synonymous with heart failure. And it is a good marker, but not a very reliable marker. And time has come when we should complement LV ejection fraction almost in all patients by GLS routinely. Next slide. And this is the last slide I'm going to show you, borrowed from the Echo Manual by Taji Kano. And I think this is a $1 million slide which summarizes almost everything. So look at the systolic function and structure of the heart. If that is abnormal, you have a simple problem in hand. You have DCM, ischemic cardiomyopathy, valvular heart disease, or congenital heart disease. But if it is apparently normal, there lies the problem. You have to assess the diastolic function. If you have grade 1 and yet you tend to think patient has heart failure, it could be pulmonary hypertension, pulmonary embolism, RV infarct, cardiac tamponade, or you do exercise if resting echo is normal to find out whether patient has exercise-induced alteration of diastolic function. If the diastolic function is grade 2 to 4, you have obvious problem in hand. You do a tissue Doppler. If E by E prime, if E prime velocity is less than 8 centimeter per second, you have a myocardial disease in hand. Probe it further with further investigations. If E prime is more than 8 centimeter per second, and yet you have a raised left atrial pressure and a raised left ventricular end diastolic pressure, the answer is constrictive pericarditis. So with that, I will end my presentation. And the next speaker I will invite is Dr. Rajesh Subro Ghosh. He is going to speak on evaluation of left ventricular size, shape, and structure, and systolic function. So over to Dr. Ghosh now.
Thank you, Dr. Kumar. Good evening, everybody. Evaluation of the left ventricle is the most common tasks that an echocardiographer performs on a daily basis. So, yet we have a great deal of variation in echo reporting on the left ventricle, which is why.
Dr. Ghosh, please make it full screen. Please make your slide full screen. Yeah.
So, when we evaluate the left ventricular function, we need to be careful as to how we are assessing the LV. And in a recent article, they mentioned that echocardiography plays an essential role in the diagnosis and assessment of cardiovascular disease. Measurements derived from are also used to determine the severity of disease, progression over time, and aid in the choice of optimal. It is therefore clinically important that echo measurements be reproducible, repeatable, and reliable. And this is a very important point because that's where the variation comes in. We know that lower LV ejection fraction is associated with a higher mortality. Larger diastolic and systolic LV volumes are associated with poorer prognosis. And in patients with coronary artery disease, LV systolic volume index is a more powerful predictor of heart failure hospitalization than LV diastolic volume index or LV ejection fraction. So what are the components which affect stroke volume? We need to look at the preload, the afterload, the contractile state of the myocardium, the geometry, and they all affect the circumferential fiber shortening, longitudinal fiber shortening, and they all affect the wall thickness and the stroke volume. So when we look at the first slide, first shot of the parasternal long axis view, we make an eyeballing assessment of the left ventricular size, the left ventricular function. We see the inward motion of the endocardium, the thickening of the myocardium, mark you, not just the movement, but the thickening of the myocardium is important. Longitudinal motion of the mitral annulus and the geometry of the left ventricle. So what do we measure in the minor axis, in the short axis view? Say we look at the fractional shortening of the endocardium, that is a very age-old measurement of the left ventricular internal dimension in diastole and systole. We can measure the velocity of circumferential fiber shortening, and we, of course, very commonly the MO-derived ejection fraction is calculated, but that is not the recommended method nowadays. And in the longitudinal axis, we can also assess the displacement of the mitral valve towards the apex by MAPC, the mitral annulus plane systolic excursion. We can assess the mitral velocity, and the velocity of movement of the mitral annulus towards the LV apex by tissue Doppler imaging. And of course, the new kid on the block is global longitudinal strain, which we'll discuss in a little while. And with the help of Doppler, we can assess the stroke volume by assessing the velocity time interval at the LV OT and multiplying it by the cross-sectional area of the left ventricular outflow tract. The TIE index and the LV DPDT are sometimes used in severe heart failure, severe LV dysfunction, and of course the mitral annulus velocity, as we mentioned. However, echocardiography has become synonymous with ejection fraction, unfortunately, and we have to assess the ejection fraction accurately. So basically, it is the difference between the end diastolic volume and end systolic volume divided by end diastolic volume expressed as a percentage. We are not accepting linear measurements nowadays. The standard of performing means that we need to use the two-dimensional method, the biplane Simpson method or the area length method. We use the apical 4-chamber and 2-chamber views to assess the ventricles, and the machine does the rest of the work and gives us volumes. Better still, if we have a 4D machine, 3D images can, if we can get a good 3D image, we can also get the accurate volumes to calculate the ejection fraction. In cases where the endocardium is not very well visualized, we need to do contrast enhanced imaging to get good pictures. Now, we assess the heart in long axis, short axis, and the 4-chamber planes. This is how the heart looks in the long axis. When we look at this cut of the heart from the parasternal probe here, we get the long axis of the heart. We look at the long axis of the ventricle. We can place the probe at the apex and get the long axis. From this parasternal position, we get a short axis view of the heart, and we can see it at different levels. And from the apical view, we can get the 4-chamber view and also the long axis and the 2-chamber views. Now, this is the first view that we get when we look at the parasternal long axis. We get to see the basal and the mid part, not the apical part in this view from the parasternal region. For the M mode, we pass the M mode beam through the chest wall, the right ventricle, the IVS, the left ventricular cavity, and the posterior wall, and we measure the thicknesses. This is how the thicknesses are measured. Everyone who was doing echo knows this system. We are just measuring the IVS thickness, the posterior wall thickness, and the diastolic dimension in the maximum diastole, where the dimension is the maximum. And then we measure the dimension of left ventricular systole, where it's the minimum, and get the mass. You can see that with these calculations, the left ventricular mass is automatically given, and if you enter the body weight and body height, the mass is indexed to the body surface area, and this is important. So if you look at the parasternal long axis view of this patient, at one glance you can make out that the left ventricle seems dilated, the left atrium seems dilated, there seems depressed function of both the septum and the posterior wall, and the overall LV function is depressed. And then we go on to make measurements. Similarly, when we are assessing the mitral, the M mode of the left ventricle, when we place the cursor, one has to be careful that the cursor is perpendicular to the long axis of the left ventricle. It should go perpendicular through the IVS, through the cavity, and to the posterior wall. This is a picture taken with the 4D probe, so that we can see exactly the cross-sectional or short axis view at this level, because we have to be careful that the cut is not from the side of the ventricle, where the ventricular cavity can be measured less than what it is. Now, the concept of this summation, this is what we do when we are assessing the ventricular volumes from the apical 4-chamber and 2-chamber views. Basically, the left ventricle is assumed to be a prolate ellipsoid, and we are supposed to trace the left ventricular myocardial compacted myocardium from the mitral medial annulus to the lateral annulus, and the machine divides up this volume into multiple small cylinders and calculates the volumes of the cylinders and sums it up, give us the volumes. Now, there are two basic methods which I used. This is the most accepted method, the Simpson's biplane disc summation method, where we have to grab good images from the apical 4-chamber and 2 chambers, and we measure them at end diastole and end systole. The important thing is not to avoid foreshortening, because the apex is the least moving part and the base is the most moving part. We can identify the proper apex. If it is not moving, that means we are at the right at the apex. If it is moving, that means we are not right at the base. There's a foreshortening. The other method is area length method. This is used when we cannot trace the apex very well. This is again the 3 planes that are used from the apical view. This image is from with a 4D probe. However, we can grab all these 3 images with a 2D probe first, starting with the apical 4-chamber view, then rotating our probe anti-clockwise by 60 degrees. We get the 2-chamber view, where the anterior wall is on the right and the inferior wall is on the left. Further rotating 60 degrees, we get the anteroseptal wall on the right and the intralateral wall on the left. So we can use these 3 images for further measurements. These top 2 images are used for the biplane Simpson disc summation method, and all 3 images are used for strain imaging. Now, so we know that M mode method of evaluating ejection fraction is in the past, 2D is what is present, and 3D is our future. A word about strain. Strain is nothing but deformation. We are actually calculating how much the length of the muscle fiber shortens with systole, and the difference is divided by the original length and expressed as a percentage. Now, there can be longitudinal strain, which is the one that we use most commonly. There could be circumferential strain, which is also a negative value because it shortens with systole, and there could be radial strain, which increases with systole. These are the 3 views that we use, and once we grab these images, the computer automatically plots the speckles. This is called speckle tracking in echocardiography, where the machine detects the speckles and plots them in diastole and systole and measures the strain values for each segment and plots them on a chart like this and gives us the average value, which is in this case minus 14.4. So a word about twist. The left ventricle also twists. Basically, the pumping function of the left ventricle is augmented by this twisting motion of the left ventricle. The apical part rotates anti-clockwise when you look at the heart from the apex, and the basal part rotates clockwise, and that can be plotted on the y-axis. The torsion is expressed in degrees. The torsion is basically the relative twisting of the apex to the base. So that's how the torsion is expressed. And when there's dilatation of the ventricle in cases like cardiomyopathy, this twisting motion is lost and the efficiency of the left ventricle is reduced. A word about the segments. When we evaluate the left ventricle, it's usually in coronary artery disease. So we need to know and talk about segment when the segments are affected in coronary artery disease. So basically, we evaluate the LV in three parts: the basal, mid, and apical part. The apex is divided into anterior, inferior, septum, and lateral. While the base and mid are further divided, the septum is divided into the anterior septum, inferior septum, and the lateral wall is divided into anterior lateral and inferior lateral. Correspondingly, one should know the coronary artery territories that supply each segment. What about LV mass? So why do we need to know about the mass of the left ventricle? Because LV mass is an indicator of target organ damage in hypertension, which is why we treat hypertension without symptoms. It is a powerful predictor of outcome in hypertension in population studies, and it is an indicator of severity of pressure overload in aortic stenosis. So as we know, this is how the left ventricular mass is measured. And if you look closely, when you do the M mode, the figure of the mass index and also the relative wall thickness is given. The relative wall thickness and the LV mass index is what evaluating the LV mass. And then on this chart, and remember which quadrant it is in. You can see this chart on this side. Y-axis is the relative wall thickness. The abnormal RWT is more than 0.42, and the mass index is up to 115 in men and up to 95 in women. This is the normal geometry pattern. This is the concentric LV hypertrophy pattern where the RWT is increased and the mass is also increased. Now, let's take a look at a few. Just a moment, I'll just share. Yes. This, just in case, is this visible? Okay. This is a real case that we are saying when we evaluate the left ventricle. We look at the parasternal long axis view. We take an M mode slice and we see that the cursor line is at a slant. So we have to correct the slant. We have to make it perpendicular. So we move the cursor line this way just beyond the tip of the mitral leaflets, but still it is not perpendicular. So we use the AMM, anatomical M mode function, to make it perpendicular. Then we are satisfied that we are cutting it properly, and then we make the measurements from M mode. Go on to the apical 4-chamber, apical 2-chamber, and apical long axis views. So as we earlier mentioned, if we go to apical 4-chamber, we take two views, the apical long, the 2-chamber over here, apical 4-chamber over here, freeze it, and go to the end diastolic frame. That is the end diastolic frame is the first frame after diastole when the mitral valve just closes. And then we do the measurements for the diastolic measurement by tracing right from here, right the endocardium up to the LV apex and going right back there to the lateral part of the mitral annulus. the machine does the calculation for the area over here. Go to the apical 2 chamber and do the same thing. Remember not to include, I'll just give a small example. We are not going to include the, say for example, this is the 2 chamber view. We don't include the papillary muscles or the chordae. We just go take the compacted myocardium. And this requires a little bit of practice, and everyone should be familiar with this method, and this is automatically calculated. I'm not going to complete this procedure because of shortage of time. And measurement from this mode, and I'll just show you how we are doing the strain imaging. This is very important because this is a very stable parameter and it's useful for follow-up. So when we want to do strain imaging, we have these 3 images, the apical long axis, apical 4 chamber, and apical 2 chamber. Go to AFI and select apical long axis. The machine does the rest. It gives you a brief, you can modify these if you want to modify the positions of the lines, and then ask the machine to process. The machine automatically processes, and we accept, approve, and select the next one. So next one is apical 4 chamber. We go to the apical 4 chamber. I'm not doing the necessary corrections. We just accept and move on to the next one. Process. And then we move on to the approve and select the next one. That is chamber view. You can correct it if you want to, and process. And this gives us all 3, and we approve the measurements. And this is how it's represented. I could have accepted this, and they will give us a value. So the value, I will not accept this result, and this was done earlier. This is how it's plotted on a bullseye chart. All the segments are measured and plotted, and we can get a value over here. The average value is given as -19, which is pretty normal. So this is how, in brief, we assess the systolic function of the left ventricle. I conclude my talk, and I request Dr. Dipankar Datta to take over from me for the right ventricle.
Yeah, thank you, Dr. Ghosh, for a very elaborate presentation, but yet finishing on time. You have given a very good demonstration of quick estimation of LV structure, function, and assessment of its systolic function. And I mean, of course, the diastolic function will be dealt with by Dr. Dey. Thank you very much. So over to Dr. Dipankar Datta, and we have been reiterating in various forums that the right ventricle and the right heart is neglected side of the heart, but often we make a very costly mistake by not assessing it properly. So over to Dr. Datta for a very lucid but useful presentation on the right ventricle, I mean on the right side of the heart.
Thank you, Dr. Kumar, for your nice introduction. As Dr. Kumar has already stated, the right heart or the right ventricle had been neglected in clinical studies and echocardiography examinations for a very long time. But the importance of right ventricle and the right heart as a whole, its function, its pressures, etc., have now become an integral part of every echocardiographic examinations. The question comes, why should we quantify right ventricle? Why it was neglected, and why it was wrong to neglect it, is because RV is just not a conduit of blood flow. It's just not a passive bystander in the cardiac function. It has its unique functions. And it has prognostic significance in various clinical statings. It's very useful in risk stratification. And it also helps to guide the optimal therapy. Why? Because the functions of right ventricle include, it maintains adequate pulmonary artery perfusion pressure to improve gas exchange. It maintains low systemic venous pressure to prevent congestion of tissues of organs. It affects left ventricular functions as well by limiting preload in RV dysfunction. There is limitation of preload in RV dysfunction, so LV gets less blood. And as Dr. Rajat Ghosh has mentioned a little bit, there is something called a ventricular interdependence between the two ventricles. And it has a significant prognostic significance in the various clinical settings. There had been 2 guidelines and recommendations recently, not very recent though, they are perhaps up for updation. One was in 2010. It was the guideline produced by the American Society of Echo and the European Society of Echocardiography and Canadian Society as well, chaired by Dr. Rudisky, which guided us to assessment of the right heart. And it was followed in 2015 by Roberto Lang-led team of AAC, which recommend the quantification of cardiac chambers, right, left, all included. These two, my measurements, my normal values, my methodology are based on these 2 papers. Since these are the most updated, most recent papers, though not updated as yet, so we go by them. So let's start. The right heart consists of, in my opinion, the assessment consists of 4 or 5 parts. One is assessment of the right ventricle, its anatomy, its pressure, its functions. Assessment of the right atrium. Assessment of the pulmonary artery pressure in particular. And assessment of the right atrial pressure by assessing the inferior vena cava. I'll come to them one by one. Right ventricular anatomy is complex because of its crescent shape. The RV wall is thin walled compared to the left ventricle, so it's very sensitive to afterload and preload, particularly afterload. And also RV dilatation and RV hypertrophy appears very easily after with changes in afterload. Echocardiography of RV assessment can be done in various ways. It can be a one-dimensional assessment like M-mode, RV diameter, wall thickness, TAPSE. It can be 2-dimensional Doppler assessment, 2D strain, 3D volume, etc. I will dwell on few of them, not all, in course of my talk. The essential windows of RV examinations includes the apical view. It can be assessed by apical 4-chamber view, or there is something called a focused RV view, where you move the probe little laterally towards the axilla and slant it anteriorly to get a better view of the right ventricle. And this view is particularly used in the focused RV view in many of the measurements of the right ventricle, which I will come to later. The other views of assessment of right ventricle includes parasternal long axis RV inflow view, the parasternal short axis view, the subcostal view. By rotation of the probe a little bit, we can get a view of the various walls of the right ventricle, which may be useful when we are trying to include or exclude RV infarction. Like in the mitral view, the lateral wall can be seen well. In the coronary sinus view, this is the coronary sinus, we see the anterior wall well. And in the aortic view, where a little bit of aorta is included in the 4-chamber view, you see the inferior wall of the RV. The assessment of the size of the RV can be done qualitatively by eyeballing. It's a very rough way of doing it. Now, if the RV size is less than or equal to 2/3 of the size of the LV visually, then we can say that the RV size is normal. If it's kind of similar to, as in the second cartoon, it's similar to the LV, it's a mild RV enlargement. If it's larger than LV, but with a reasonably normal shape interventricular septum, it's a moderate RV enlargement. And if the RV appears very large with a D-shaped septum, we can say it's a severe RV enlargement. But we have to measure them quantitatively as well. The RV size quantitatively estimation is done, as I have said, mostly from the apical 4-chamber view. maybe RV focus view. The three measurements are taken for the RV size here. One is the longitudinal dimension of the RV, where the normal value of 86. RV is also measured at the mid diameter in the end diastole with the maximum accepted value of 35 millimeters, and the basal diameter, which is very important and which I particularly use, is also measured again at the end diastole at above the mitral at the tricuspid annulus, where we get the maximum diameter, and the normal values up to 42 millimeters. And as I've said, all are measured at end diastole in RV focus 4-chamber view. The image has to be optimized to get the maximum diameter without shortening the RV, and which I have spoken about. This is from Roberto Lang's 2015 guideline, where it's again shown in an RV focus view. This is where we measure the mid-ventricular dimension of RV. This is at the basal level. We can also measure the RVOT in the parasternal short axis view, as has been shown in this picture. And the RV outflow tract can be measured in the parasternal short axis view, which is again shown in the next slide. It comes like this. You take a pulmonary artery focused RV outflow tract view. At the center level, this is where we measure the RV outflow tract diameter. This is the proximal RV outflow tract diameter. The distal RV outflow tract diameter is taken just above the pulmonary valve. And we can also measure the diameter of the pulmonary artery here. And the last measurement of RV I'm going to talk about is the measurement of the RV free wall thickness. It's best done in the subcostal view, and the measurement is ideally taken close to the tip of the open anterior leaflet of the tricuspid valve. We can zoom the picture and measure the RV free wall thickness. The normal value is up to 5 millimeters according to the guidelines. This is a very busy chart. I will not go into this. This outlines the normal values of RV chamber size, and it is available in the guidelines, and it's available in many books as well. Now next, let us come to the assessment of RV function. Now, why RV function is important, I have already said, but there are certain limitations in measurement of the RV function in the armamentarium we have as of now. There is difficulties in estimation of RV volume because of its peculiar crescent shape and because of the separation between the RV inflow and the outflow tract. And there is no uniform geometric assumption for measurement of the volume. As Dr. Rajat Ghosh was saying, there is a left ventricle is considered as a prolapse ellipse or kind of a bullet shape. There is no geometrical assumption like that for RV measurement of RV volume. And there are difficulties in delineation of the endocardial border of the RV because of its dense and very well-developed trabeculations. The difficulties in getting the adequate image acquisition owing to its location just behind the sternum. Moreover, there are difficulties to standardize the evaluation methods of RV function because there is variation in the direction and location of RV. It's easily affected, as I've told before, by preload, afterload, and LV function. Why? Because RV is a reasonably thin-walled cavity, and so its pressures are easily affected by preload, afterload, and as I've told, by LV function as well. Different complex contraction relaxation mechanism of various segments of RV also make it difficult. And lastly, but not the least, it's not possible to image the entire RV in any one single view. The measurements of RV function are, we can measure its longitudinal function. We can also make a volumetric assessment of its function. And we can, like LV, we can also measure the RV global longitudinal strain. I'll come to them one by one. But at the outset, let me tell you, every echo report, according to the recommendations, must contain at least 1 or 2 parameters of RV function. Otherwise, the report is considered inadequate. TAPSE, or the tricuspid annular plane systolic excursion, is a very easily determinable parameter of RV longitudinal function, where what we do is we take an M mode in the RV focused apical fourth chamber view and M mode of the RV tricuspid annulus. But we have to be very careful to run the plane as parallel to the long axis of RV as possible, or parallel to the long axis of the motion of the tricuspid annulus as possible. And it's measured. I'll show it once more later. There is a pulse wave tissue Doppler S wave velocity of the tricuspid annulus and global longitudinal strain. I'll come to these three one by one. The TAPSE is an indicator of the RV function, longitudinal function of RV, and it's shown here as I have spoken before. It has its prognostic value in congestive heart failure and pulmonary hypertension. It is considered abnormal if it is below less than 1.7 centimeters. But the problem, the limitation, it's angle dependent. So you have to cut the plane well. It has a 53% specificity, and but it assumes only one segment representation of the function of the complex structure of RV. So global function is always better. And it's the problem of TAPSE and tricuspid valves S prime are that they get stunted after cardiac surgery. So these values are not reliable when we are assessing a patient after CABG or other cardiac surgeries. The tricuspid lateral annulus S prime is a tissue Doppler derived dimension of the velocity of motion of the tricuspid annulus in the longitudinal plane. But that we take a tissue Doppler with the sample volume at the tricuspid annulus, and we measure the S velocity of the annulus. The normal value is up to above 9.5 centimeters per second. RV strain analysis is coming in a big way now. A lot of the machines, the newer machines, the high-end machines of companies are coming with. Previously, what we used to do, we used to kind of fool the machine by using the LV strain algorithm or LV strain functions to measure the RV, but the machines are coming with independent RV strain measurement software these days. As in LV, the RV strain is measured the same way. It can be measured in two ways. Either we measure the free wall strain, or we measure the 6 segments strain of the entire RV. And the normal values is 20% or less. Less means 21, 23, because since it's a negative value in the 6 segment model, and 23% in the 3 segment module. RV area also has to be measured, because there is something called a RV fractional area change, which is an important and useful parameter of assessment of global longitudinal strain, though it's a two-dimensional parameter. And in which what we do is we may freeze the RV in the RV focus view at end diastole and in end systole, and we plot the RV area. And as in the LV ejection fraction, the RV end diastolic volume minus the RV end systolic volume divided by the RV end diastolic volume gives us the RV fractional area change. And the normal value is 35% and above. But here it's very important to have to cut the RV properly. Otherwise, for the same patient at the same point in time, if the sections are not done well, it can give us very different values. And the RV longitudinal global function can be assessed by RV index of myocardial perfusion of the tie index, and it can be done by pulse Doppler as well as tissue Doppler, where in both the methods, the total tricuspid valve closure opening time is measured, as well as the ejection time is measured, and the pulse Doppler derived tie index is total closure opening time of tricuspid valve minus ejection time divided by the ejection time. Whereas in the tissue Doppler, it's slightly different, and the values are also different. I will not dwell into detail because of the shortage of time, but the normal value in the pulse Doppler is greater than 0.43, and In the tissue Doppler, about 55%, 0.55. The 3D echocardiography is also coming in a very important way in measurement of the RV structure, size, dimensions, functions. But it has its limitations because of its non-availability, difficulty in training and acquisition, etc. But this is something of the future. This is from the Roberto Lang's paper of 2015, where they have said the ejection fraction derived by 3D echocardiography, 45% or above is the normal value. But with the newer machines, it's becoming easier now because all machines are including RV3D algorithm in their high-end, all companies are including in the high-end models. So this is something of the future. As it was shown in Dr. Roger Ghosh's slide, 3D is the future of LV assessment, so it is for the RV. The RV diastolic function is also measured the same way as the LV diastolic function, which Dr. They will be talking later. At the tricuspid valve recording for the EA velocity above less than 0.8 suggests impaired relaxation of the grade 1 dysfunction, and one above 2.5 with a deceleration time less than 120 seconds suggests a restrictive feeling. And intermediate value where we have to bring in the other parameters of RV diastolic function to assess the RV diastolic function. Let's come to RV pressure now, which is very important. Because RV pressure, or indirectly the pulmonary artery pressure, the pulmonary arterial hypertension, the survival of the subject is greatly affected by presence or absence of pulmonary hypertension, as it can be seen in this graph. With the survival, even in the modern era with all the treatment, the survival is pretty dismal once the patient develops pulmonary hypertension. And how do we measure the RV pressures? Previously, when there was no Doppler, this was the way. When we started doing echo, we used to get an idea of the pulmonary hypertension. We used to take an M mode of the pulmonary valve in the parasternal short axis. There used to be flattening of. Normally there is a dip here, which is called the A wave of the pulmonary. This used to disappear in pulmonary hypertension, and there is to be a post-systolic notching, which is known as a flying W. This was the way you used to kind of assess or comment about pulmonary hypertension when we first started. But with the advent of Doppler, color Doppler, everything has changed. And the pulmonary artery pressure, we try and get an estimate of the systolic, diastolic, and the mean pulmonary artery pressure by various ways, which will come to one by one. And we may also can measure the pulmonary vascular resistance, which is very important determinant of pulmonary hypertension. The measurement of TR-jet or the peak TR-jet velocity plays a very important role in measurement of pulmonary artery mean, and if we can plot the TR spectrum totally in measurement of the mean pulmonary artery pressure as well. And there are 5 views by which we can measure the TR velocity, and we have to try every of these 5 views in every patient, and we have to take the maximum what we get to determine the pulmonary artery pressure. Because by measuring the TR-jet velocity and the pressure, we get an estimate of the RV pressure, and RV pressure is considered equal to the pulmonary artery pressure if there is no pulmonary outflow tract obstruction. And the TR-jet is obtained, the spectrum is obtained, and velocity is measured, and the systolic pair pressure is from the modified Bernoulli's equation is 4 into the TR-jet velocity to the power 2 plus the estimated right atrial pressure. But there are some pitfalls because the flow depends on the effect of blood pressure and the stroke volume. It can automatically or normally, and measurement of TR-jet has to be done very carefully. We have to measure the TR-jet at the chin, not at its beard. I'll come to a few more slides like that later. There is a reason why the interventional cardiologists do not differ with us when we give a pulmonary artery pressure, because we sometimes tend to measure the TR-jet peak velocity not at the proper place. we don't have measured the hair, we have to measure the scalp. And the main reason of getting a wrong TR peak velocity is our rich imagination and overgain signals. As you can see in this overgain signal, obviously the TR jet is overestimated, and this is what happens. If we measure the TR jet here, and if we measure it here, there is a gross difference between 2.9, where the pulmonary artery pressure will come as 30, or the RV pressure will come as 34 millimeters, or if we use an overgain signal, it will come as 52 millimeters, same here. And if we use our rich imagination to think that the TR jet is here, we get a value of 92 against the proper value of 49, which is here. So we have to be very careful when we are measuring the TR jet velocity. What helps us to get a proper TR jet, and I can assure you in over 30% of the cases, or maybe more, you will not get a proper TR jet to estimate the velocities and the pressures. What helps in these circumstances is the use of contrast. And a plain saline contrast is useful. Like the same patient where we were not getting a proper TR jet, with the use of saline contrast, we get a much better TR jet, helping us to assess the pressure and the velocity much more accurately. Mean pulmonary artery pressure is very important, and the pulmonologist will ask for it, because I can, by definition, pulmonary arterial hypertension is a mean pulmonary artery pressure of over 25 millimeters, though there is a corollary, it has to be measured by cardiac catheterization. But the echo-derived mean pulmonary artery pressure can most reproducibly and reliably measured from the TR jet velocity, as has been documented and advised in various recommendations and guidelines. And we have to get a proper tricuspid regurgitation spectrum. We have to plot it, and the machine will give us the mean RV systolic pressure, with which we add an estimate of right atrial pressure, and we get the mean PA pressure. If we don't get a proper TR jet, there is various formulae by which we can get an idea of the mean PA pressure, which includes the Mahan's equation, but these are not very reliable and not very well accepted. What we have to do in Mahan's equation, we have to get a spectrum of the PW spectrum of the pulmonary vein Doppler, and we have to measure the acceleration time, and by these formula, either this or this, we can get an idea of the mean pulmonary artery pressure. But to get a very rough estimate, if pulmonary artery activation time, acceleration time is above 120, the PA pressure can be taken as normal. And if it's between 70 and 90 or below, it means severe pulmonary hypertension. PA diastolic pressure can be measured from the pulmonary regurgitation continuous wave Doppler spectrum or the pulse wave Doppler spectrum. And it is the end diastolic PR velocity, 4 times end diastolic PR velocity square plus the estimated RA pressure is taken as the diastolic PA pressure. If we get a good pulmonary artery, vein Doppler spectrum, or the RV outflow tract Doppler spectrum, the peak velocity at the beginning is roughly equal to the mean pulmonary artery pressure. But there is a, I would say, this is very important. Some of the places do it wrongly. The right atrial pressure need not be added to this. This value itself is the mean pulmonary artery pressure roughly, though not very well accepted. But the pulmonary, how do we define pulmonary hypertension on echo? It should not be defined by the pressure, because pressure, where there is always an approximation of adding the right atrial pressure. So this chart guidelines that if the pulmonary, if the tricuspid regurgitation peak velocity is less than 2.8 meters per second, and there is no other secondary sign of pulmonary hypertension, then the echocardiographic probability of PH is very low. If it's between 2.8 and 3.4, it's intermediate. in presence and absence of indirect signs. And if it's between 2.9 and 3.4 and above, if it's between 2.9 and 3.4 with the indirect sign, there is a very high probability of pulmonary hypertension. And if it is above 3.4, there is definitely pulmonary hypertension. And the indirect signs include the right ventricle is to left ventricle basal diameter ratio, the pulmonary artery size, and the inferior vena cava and right atrial pressure. But what is very important to understand is how we should define mild, moderate, and severe pulmonary hypertension. We shouldn't define it by the RV systolic pressure, not by the ratio of RV systolic pressure to the systemic blood pressure. We should define it by the severity. We should define the severity by the degree of RV dilatation, RV dysfunction, RV pressure elevation, and decrease in cardiac output and index. Now let's move on to pulmonary vascular resistance. I will not go into detail because of shortage of time. It used to be a very cumbersome method of the calculation of PVR because it's basically the transpulmonary pressure divided by the transpulmonary flow. But it's an important determinant of survival of the patient. As the pulmonary vascular resistance goes up, the survival goes down, as it can be seen in this chart, in this diagram. A simple method of determining of pulmonary vascular resistance was devised by Abbas et al. And it can very simply be determined by pulmonary vascular resistance is 10 into tricuspid regurgitant velocity divided by tricuspid time velocity integral, or the RVOT, time velocity integral. And the formula for that is TR velocity maximum divided by RV time velocity integral into 10 plus 0.16 is the pulmonary vascular resistance, which is given by the, which is expressed by Wood unit. And as can be seen in this picture, you take a tricuspid regurgitant spectrum, you measure the peak velocity, and you, in the RV outflow tract, you measure the time velocity integral, put it to this formula, and it's integrated in many of the machines. And you get the pulmonary vascular resistance, and the normal is below or equal to 3 Wood unit. Next, let's come to the measurement of the right atrium, which is gaining importance as the time is coming. We get a proper right atrium focused 4-chamber view, and we have to measure the major diameter, the minor diameter, and we can also measure the RV area. This is from Lang's paper once again. The linear dimensions, as I have said, are measured the major axis and the minor axis, and the RV volume can be measured by the summation disk method or the Simpson methods by plotting the RA, proper view of the RA. And the normal values are, our normal value of RV volume is above 18 centimeters square. The major diameter is 53 up to normal is up to 53 millimeters, and the minor diameter up to 44 millimeters. RS strain is also coming, but this is still at an experimental and in the laboratory stage. I will not dwell into that. Measurement of inferior vena cava is an integral part of all echocardiographic examinations. Unless you measure the inferior vena cava, whether it's an outpatients, inpatients, or whether in ICU, the study is not complete. Because it's a very important inferior vena cava measurements determines the, what we call the volumes, the central volume status of the patient, which is very important in treatment of the patients, particularly in the critical care settings. And it is mandatory to measure the inferior vena cava to get an estimate of the right atrial pressure, which in my previous slides I have shown. In order to determine the pulmonary artery pressure, you have to know the right atrial pressure as well. And the inferior vena cava is measured, the diameter is measured from the subcostal view with the inferior vena cava, with a focus on the inferior vena cava, and it's measured perpendicular to the long axis of the IVC at end expiration, just proximal to the junction of the hepatic vein, which goes like this from here, and approximately 0.5 to 3 centimeters proximal to the ostium of the inferior vena cava into the right atrium. And it can either, I'm very sorry, this cartoon, these are not moving. There was something wrong. The inferior vena cava can be normal sized with normal collapsibility with sniff. It can be dilated but collapsing normally with sniff. It can be normal sized but not collapsing with the sniff, and it can be dilated and non-collapsing. And these are important determinants. This is from Lang's latest guideline, where previously what we used to do, we used to arbitrarily add 10 millimeter of mercury as the RA pressure. Stop doing that, because the guideline says the inferior vena cava diameter is 2.1 centimeters and collapse more than 50% with a sniff. We have a normal RA pressure, which is between 0 and 5 millimeters. And if you are trying to add it to get the pulmonary pressure, you add 3 millimeter mercury. If it's above 2.1 and collapses less than 50%, it has a high RA pressure, and we add 15. It's between 15 and 20. We add 15 millimeters to that. And if it's in the indeterminate range, where it's either normal sized and not collapsing, or it's dilated and collapsing well, we add 8 millimeters of mercury to the peak tear velocity, peak tear pressure, and get the pulmonary artery pressure. Like I think Dr. Ghosh, Dr. Dev will be talking about that. We measure the pulmonary venous flow to get the get an idea of the left atrial pressure. We can get an idea of the right atrial pressure by plotting the forward venous flow of the hepatic veins. I will not dwell into detail because I think I'm already short of time. So the summary message is quantitative measure of RV size and function have huge prognostic values regarding exercise tolerance and outcome. RV pump function depends on contractility, preload, afterload, heart rate, rhythm, and valve function. RV function in left heart disease has an additional prognostic importance. Knowledge of advantages and limitations of modern imaging modalities helps to obtain the accurate RV diagnostic information. 3D echo and strain are coming in a big way, and multimodality of RV is also needed. I again go back to these guidelines. Please download these two guidelines and perfect your methods and practice them to get a proper assessment of the right heart. I don't know whether this presentation has made you happy or unhappy, but anyway, thank you very much for your kind attention.
Yeah, thank you, Dr. Dotto, for your very elaborate presentation on the right side of the heart. In the interest of time, I'll quickly call upon Dr. Aniruddha De to make his presentation on evaluation of LV diastolic function and the left atrium.
Thank you, Soumitra. Only problem is that already everybody overstood the time for about near 45 minutes. So already is 7:15. I'm starting. Whether if everybody feel bored, then you can stop me anytime. No problem. Anyway, I'll share my first screen. Well, the importance of the diastolic function and the left atrium. It is already highlighted by Dr. Soumitra Kumar regarding the importance of the diastolic function. So I did not have to tell you. But before assessing the echocardiography assessment of the diastolic function, there is a very important thing to note is that you have to take the clinical profile, heart rate, blood pressure, or any rhythm abnormality. LV size and the basic echocardiographic parameter like LV size, wall thickness, regional wall motion abnormality, LV volume, ejection fraction, LA volume, and the morphology of the mitral and the other valves. Third point is that suboptimal Doppler signals are not included in final evaluation of the LV diastolic function. And the fourth important point is that single normal measurement will not indicate normal diastolic function, because several hemodynamic factors affect any particular signal. Hence, no single parameter should be used alone. basically the diastolic function till now, we are based on the ACVI diastolic function guideline in 2016. But after that, the galaxy of literature actually challenges this update, update with certain literatures. But still, we are following these 2016 guidelines because we don't have any other comprehensive guidelines till such. But what is deviated from the 2016 guidelines, I'll tell in during course. But the most important slide in the criteria for the diagnosis of LV diastolic dysfunction is this. First is the diagnosis of diastolic dysfunction in the patient with the normal LVF. Whether there is diastolic dysfunction patient present in not in case of normal LV ejection fraction, that means not up more than 50%. LVEF more than 50%. Where 4 parameters are used. Either you have to take average E by E prime is 14, septal E prime less than 7, lateral E prime less than 10, TR velocity more than 2.8 meter per second, and LA volume index is 34 milliliter per square meter. If 3 or 4 are positive, then definitely there is the patient is having diastolic dysfunction. If none or 1 positive, normal diastolic function. If 2 positive, then 2 negative is indeterminate. Now, verified after that, next is a slide that evaluation of the left ventricular filling pressure, what Dr. Soumitra Kumar is used to tell in his address, that you have to evaluate the left atrial pressure or the estimation of the left ventricular filling pressure in patient either with depressed LVF or with normal EF with diastolic dysfunction. So even if there is a diastolic dysfunction is there, or there is a systolic dysfunction is there because there is a decreased LVEF, we have to evaluate the LV filling pressure. For that, you first do E by A ratio. If E by A ratio is less than or equal to 0.8, or E is less than 50 centimeter per second, second value is E by A 0.8 plus more than 0.8, or E is more than 50 centimeters per second, or E by A is in between 0.8 to 2. That means more than 0.28 and less than 2. And third is if E by A ratio is more than 2. If E by A ratio is more than 2, you will definitely there is a increased LAP and probably you are dealing with the grade 3 diastolic dysfunction. Now in the first criteria where E by A is less than 0.8 or E is less than 50 per second, probably there is a normal LAP. Now lies in between intermediate one, where you will get 3 criteria to be evaluated, other 3 criteria to be evaluated, like average E by E prime ratio is more than 14, TR velocity is more than 2.8, and LA volume is more than 34. If again, out of 2 is positive, out of 3 is 2 or 3 is positive, then again the LAP is increased. Obviously, then it is a grade 2 diastolic dysfunction, or we call it a pseudo-normalization pattern. But if 2 are negative, then again the normal LAP. But if only 2 criteria are available, then 1 positive and 1 negative, then you cannot determine the left atrial pressure and the diastolic function. Of course, there are certain variations that I will talk in later. So, to determine the diastolic function, 4 parameters you have to use, that is must. One is transmitral Doppler inflow, one is tissue Doppler imaging, another is LA volume index, and the tricuspid regurgitant velocity. So these 4 are must, you must remember. Other parameters you may or may not need. So first is the transmitral Doppler inflow. That you will do, what you do is put a color flow in the apical 4th chamber view, and then put the pulse wave cursor just at the tip of the mitral annulus, and you will find the mitral inflow velocity, the early diastolic wave and the late diastolic wave, E and A. And you can see in a better way in another zoomed view. And what we measure is the E velocity, A velocity, and the E by A ratio, and the deceleration time of the E wave. Next is the tissue Doppler. So what we do, we put the cursor at the medial and the mitral annulus, and and record the tissue doublet velocity, both E prime and the A prime. How? So before going into this slide is a very important slide to recognize the E velocity and A velocity. First, whenever you put the tissue doubler in the either in the medial or the lateral annulus, the first wave is you get the isovolumetric contraction. Then you get the systolic wave, and then is the isovolumetric relaxation, this one, and then you get the E prime, and then you get the A prime. Okay, so that is the most important thing you have to remember while addressing the tissue doublet velocity in any of the annulus. And I'll show in my video also the same thing. You put the cursor in the just at the medial annulus at the junction of the ventricle with the mitral annulus, and same in the lateral one. And what you get a tissue doublet velocity like that. And so this is the medial annulus, septal mitral annulus tissue doublet velocity. There is the lateral mitral annulus tissue doublet velocity. And here you can see the Doppler settings and the sample volume is absolutely optimal. But if the sample volume is not to be put in the ventricular wall or not to be put in the left atrial wall, it's said to be put at the junction of the mitral annulus with the ventricle. But Doppler settings should not be suboptimal with the low gain to get the false result. But then you can calculate E by E prime ratio. But there are 5 important caveats you must remember. The estimation of LOP by E by E prime ratio is not recommended in significant mitral regurgitation, but more than moderate mitral regurgitation due to large regurgitant volume. As a result, E prime increases due to the resultant rise in lengthening load and hence cannot be used to correct PEF velocity. Second, E by E prime will not reflect increased LAP in mitral stenosis because increased EF velocity is more due to orifice narrowing than reduced compliance or impaired relaxation. There is rigidity and tethering of the mitral apparatus also, which may reduce the diastolic recoil of the posterobasal wall in mitral stenosis and further causing reduction in the annular E prime velocity. Third, E by E prime ratio falls to evaluate LAP precisely in patient with the left bundle branch block and cardiac patient because septal E prime velocity is underestimated due to improper alignment and paradoxical motion of the ventricular septum, whereas estimation of the lateral E prime is also undermined in LVBB due to clockwise rotation and swinging motion of the left ventricle. Fourth is that E by E prime ratio is also not used to evaluate mean LAV, mean LAV in constrictive pericarditis. Here, lateral E velocity is usually reduced due to calcified pericardium, but medial E velocity is increased compensatory, which we called as annulus reversus, which is usually lower normally. Hence, estimation of the LAP by using the hyperactive medial E velocity may be fallacious, which is actually normal. That's why it is called annulus paradoxus. And last, evaluation of the E by E prime ratio is not done in patient with the significant mitral annular calcification. Mitral EF velocity will increase due to reduced mitral valve narrowing in MAC. These tissue calculation also reduce the E prime velocity and fail to reflect the relaxation abnormality. But here is again a new criteria has come in a case of MAC that I'll tell you in due time. In the meantime, I'll just go a brief about the LSIH. This is a very important that LSIH is no longer done by M mode. What we do is either biplane Simpson's rule or the area length. Both are equal, good. But I usually prefer biplane area length method. And there is a formula, that is you can take the area in the 4th chamber, area in the 2 chamber, and there is a formula is 0.85 into area A into area 2 divided by L. What is L? L is the length you'll take from the mid plane of the mitral annulus to the superior LA, and whichever is the lower or machine automatically takes it while calculating the LA volume. And LA volume, but one important criteria has been given in a paper of estimation of LA in 2020, just in the last month of the JES, where you must see what is important is that the LA and LV is not aligned in single. Whenever you are taking the 4 chamber view, not to force certain the LV, that time LA may not be the maximum. So you must be very careful that, yes, very important, that optimization of the LA optimum by acquiring dedicated non-force certain apical 4 and 2 chamber view in which LA cavity is maximized both longitudinally and transversely. That is different plane orientation from the conventional apical views optimized for the left ventricle. That you have to remember while measuring the LA, not from the conventional apical 4 chamber view we do for the left ventricle. Next, you zoom in the LA, including the mitral annulus and the superior LA roof. Then trace the blood tissue interface in both views at end systole. That is what it must be measured at end systole. That is just prior to the mitral valve opening. Then adjust LA length in a direction perpendicular from the midpoint of mitral annular plane to the midpoint of LA superior wall. And the importance is that if properly acquired, LA length should not vary by more than 5 millimeter in between the 2 chambers views, both 4 chamber and 2 chamber view. Then you are correct. When tracing the LA wall, of course, you know that we do not, tracing the LA wall, tracing the LA wall, we do not take the pulmonary vein and the LA appendages. Of course, the LA volume should be indexed to the body surface area. So after indexing the body surface, know that 34, anything less than 34 is normal and anything above 34 is abnormal. It can be mildly, moderate and severe. It is written in the chart. And the fourth parameter we have to need is the tricuspid regurgitant velocity, why Dr. Dipankar Dutta has elaborately described to find out how to determine the tricuspid regurgitant velocity. So I'm not going to the detail. But here is the importance is there. There is the importance of the Valsalva. This maneuver is done by continuous recording and the patient is, the method you must follow properly. Then patient is asked to perform forced expiration for 10 seconds. During the procedure of mouth and nose should be closed. Measure the mitral flow inflow parameter E wave, A wave and E by E ratio at rest during peak strain and subsequent release. In normal individual, what is happening? There is reduction of the mitral E and the A velocities with more than 20 centimeter per second of E wave. And there is lengthening of the DT with no significant change of E by A ratio. However, in case of wherever you get the pseudonormal filling, the reduced transmitral flow increases LV operational compliance with reduction of the E by E ratio. So that is very important. During the strain phase of the Valsalva maneuver, if E by A ratio is decreased by more than 50%, is highly suggestive of increased LAP. Hence, reduction in preload during Valsalva maneuver actually differentiate normal from pseudonormal filling. There will be proportionate reduction of the E and A wave velocities in the transmitral flow by Valsalva maneuver in normal filling pattern, whereas reduced transmitral flow in pseudonormal filling escalates operational compliance of the left ventricle and subsequent reduction of the E by A ratio due to delayed relaxation. Here is a slide you can see. This is the mitral inflow. E by A is 1.3. And when you give the Valsalva, E by A is 0.7, almost 50% reduction. So it's not actually not a normal, it's actually pseudo-normal type of pattern. And when you do the continuous recording, from there is a normal, from the pseudo-normal to the E by reduced E by A ratio. You can see gradually in the continuous recording. Another important finding in the transmitral velocity is the LOMs. It's very important to recognize because LOMs are seen occasionally when the mean LAP is increased. It's an abnormal mid-diastolic flow due to strikingly prolonged LV relaxation during transmitral Doppler imaging. LOMs are best seen when E by A waves are well separated and A waves are absent as in atrial fibrillation. Even in atrial fibrillation, you can measure it. A waves more than 20 centimeters second only are clinical significant. Like in this picture, you can say that is almost 40 milliseconds. Another important transmitral Doppler is IVRT. That is necessary sometimes in a certain situation, particularly when you will discuss in diastolic physiology or diastolic measurement in certain clinical conditions. One of the earliest indicator of impaired LV relaxation is IVRT. See, A short IVRT designates that mean LAP is raised, normally 70 to 90 milliseconds. But short IVRT may be seen in young individual, young healthy individual. Healthy individual due to first relaxation. So how to measure is that you measure the IVRT is that you prolongation of the IVRT and you have put the cursor just at the LVOT where you can see both the mitral flow also at the aortic flow, and then you measure the distance between the end of the aortic closer to the opening of the mitral valve. So this is the measurement you can do in the IVRT. Why IVRT is important that I told you. Here is the mitral annular calcification, and this is the chart is given in the 2017 by the Abu Diab by et al, and it has been accepted by all over the world. So where you get the mitral E by A 0. less than 0.8, that means normal LVEP, and more than 1.8 is the high LVEP. But in between, that is the indeterminate one, 0.8 to 1.8. In a case of mitral annular calcification, you have to determine the IVRT. If it is more than 80, that is the normal LVEP. If it is less than 80, that is the high LVEP. I'll not, because of the lack of time, I'll not go into the details of the pulmonary venous Doppler. Well, the pulmonary, rather I'll know how to determine. See, it is the, whenever we do this, is the systolic wave, diastolic wave, and the atrial reversal wave. And what is this? How is to know that is that you have to zoom the LA and you have to find out all the pulmonary valves. You can see 1, 2, 3, and 4. And now put the color, and it should be aligned from the apex absolutely straight is the right superior pulmonary valve. In the next phase, you can see the beautiful flow in the, and you reduce the scale to 30 to 40, 30, then near about 40, you can keep this scale, and you can find out the right superior pulmonary venous flow with the corresponding Doppler in a way. So pulmonary venous Doppler is needed in some other areas, but pulmonary venous Doppler, but peak, what is important is that is the most important parameter in this here is the ARA duration. That means whenever atrial reversal, you find out the atrial reversal wave duration and the mitral inflow velocity A duration, you difference it's more than 30 milliseconds, then there is obviously dealing with the increased LAP. Mitral inflow propagation velocity was doing, we are not doing routinely in this. I am not going into detail. But one thing I must tell you, there is a newer thing is now coming, and it is being used, and it has to be used in certain condition, is the echocardiographic time interval, TE by EDAS, as the onset of mitral inflow and the onset of EDAS in TD. That means you take from the R wave to the initiation of the mitral inflow, and that from the R wave to the initiations of the E prime, and take the difference. That is called tissue Doppler echocardiographic time intervals. That is the 2 time intervals are measured, one between the tip of R wave in the ECG and the start of the mitral E velocity, and another between the tip of R wave in the ECG and the beginning of the U velocity. Most important that you have to do the 4 annular sites, both mitral and lateral in the 4th chamber and the medial and lateral in the 2 chamber. So, and then can average, but there is a no clear-cut demarcation value of the only echocardiographic time interval. But what is important is that the ratio of IVRT and the interval ratio. If it is less than 2, was found to be sensitivity and specificity of 90% for detecting a pulmonary capillary wedge pressure more than 15. And it is essential in certain conditions. Then, of course, the Soumitra requested that you have to do the diastolic stress test, like indicated where is indicated in dyspnea, the diastolic dysfunction in grade 1. See, remember, when there is a grade 2 and grade 3 at the reversible or irreversible restrictive type of diastolic fraying, you do not have to deal with. Patient is already in the failure. We do not know the patient is having the normal ejection fraction, almost normal to mild impaired relaxation diastolic parameter, but the patient is still clinically dyspneic. Then you have to do the diastolic statement. Perform using supine bike or a treadmill testing. What you record mitral inflow, annular velocities, and the TR by continuous wave Doppler at rest, during exercise, and 1 to 2 minutes after termination. Why? Because during exercise, E and AOM may be fused, and which will be again separated within 1 to 2 minutes of cessation of exercise. It is positive, it is considered positive when all three findings are made during exercise or recovery. That is, average E by E prime ratio is more than 14, septal E by E prime ratio is more than 15, or the peak TR velocity more than 2.8, or the septal E velocity is less than 7. So here you can see the 5 centimeter E prime is that E is 50 centimeter and TR is 2.6. But here after diastolic stress, E is remains same the 5, but E is 95 and the TR is 335. That means here is all the three criteria of the positive. So is a positive diastolic stress test. Now is the grade of diastolic dysfunction. Grade we already know, I am not elaborating. The impaired relaxation where there is a mismatch between the energy requirement and supply. The ventricle does not relax fully. Left atrial contribution augmented. That's why you are getting more AO. Grade 2 is the pseudo-normal pattern. In addition to grade 1, left atrial pressure rises, causing pseudo-normalization of the flow pattern. And grade 3 is the restrictive pattern. The ventricle is so steep and non-compliant, even atrial contraction cannot make it accept more blood, or the atria become failed also. So this is the chart you see everywhere, where you begin the mitral inflow, pulmonary venous flow, mitral annular velocity, or the coloring mode. But the most important slide I must tell you, this is very, very important, is that where there is a, you can get the mitral E by A is more than, equal to or more than 0.8. Average E by ratio less than 10, peak TR velocity is less than 10, LA volume index is normal. That means you are doing normal. Grade 1, literally like that, in between the same thing, but grade 3 is more than 2, more than 14, and more than 2.8. That means LAP is increased. Everything is increased. But grade 2, it may, the average E by ratio may fall in between 10 to 14. So it is in the indeterminate range. Now there are certain things I must mention, how to determine the increased LV filling pressure in absence of significant MR. LA volume index, all are same. Here, HCM patient ARA duration is more important. Other is almost same. But whenever there is a significant MR, where only peak TR velocity and the ARA duration is the most important parameter. Similarly, in a case of atrial fibrillation, is very, very important. We have to determine the diastolic parameter, where you can do the DT less than 160 millimeters, peak TR velocity 2.8, or even the mitral diastolic velocity acceleration time. You can do the more than 1900. But the most robust parameter in each and every literature they told is IVRT less than 65 and E by E prime ratio here is only 11. If it is more than 11, you are definitely dealing with the increased LV filling pressure, LA pressure. But what is important that at least 10 consecutive mitral E and annular E velocities may be averaged because of RR variability. But due to lack of time, sometimes we may not be able to do the 10 fill. Then there is an alternative method is that the 3 non-consecutive E and E prime velocities may be averaged with variation of heart rate between 10 to 20%. If the heart rate variation is in between 10 to 20% and 3 may not be consecutive, 3 non-consecutive, you take the average. You can take the average of 3-1. But remember, here is one important point. The lack of variation is itself is a pointer that the LAP is increased in case of atrial fibrillation. In mitral stenosis, again, the IVRT is important. Here is the IVRT and the time interval ratio is very important. It has to be less than 4. Where in the mitral regurgitation, again, IVRT and the IVRT and time interval ratio less than 3. This is the only difference I'm pointing out. There's the lack of time. Aortic stenosis is the standard guidelines, but in case of aortic regurgitation, That is that there are the few parameters that is very important. Then average E by ratio, E by prime more than 14 and 2 point is you can take it. But in addition, the premature closure of the mitral leaflets and the diastolic mitral regurgitation, a very important parameter for case of aortic regurgitation. In mitral prosthesis, again, there is a problem with the E prime velocities. So increase mitral E velocity, here is a decreased E prime velocity, increase E by E ratio, LA pressure may not be elevated. Pulmonary venous Doppler, here is the important of pulmonary venous Doppler, peak velocity of tear and the ratio of again the IVRT and the time interval, very useful alternative. But you have to exclude the paravalvular regurgitation and the dysfunction, mitral valve, prosthetic valve dysfunction. Atrioventricular block and pitching is very important because whether E and A become fused, then E by E prime ratio is not useful in patient with the LVBB, and even after implantation of the pacemaker that I told you in the cavity. So what's most useful indicator for LV filling pressure, where may not be the only indicator, is the peak tear velocity. In the pericardial constriction is a very important to differentiate in from the diastolic dysfunction that I already Soumitra has told you, but here is the actually the 2016 guidelines where you do the mitral inflow chart is very important. Inflow E by A more than 8 plus dilated benign vena pattern. If it is no, then is the constriction, the restriction is unlikely. If it is yes, then you know the ventricular septal mission abnormality with respiration. No, further imaging like cardiac catheterization or the constrictive pericarditis still suspected. If it is yes, then take the mitral E velocity, that whatsoever it is sold, that is more than 8 seconds, 6 to 8 centimeter and less than 6 centimeter. If it is at more than 8, that is constrictive pericarditis. If it is less than 6, that is restrictive cardiomyopathy. But if it is 6 to 8 centimeter, that is a mixed constriction and the restriction. Then you have to do mitral lateral E velocity is more than mitral medial E velocity, that is the annular reversals. Then most likely, then it is most likely constriction. Then you of course supplement with the hepatic vein expiratory endostolic reversal velocity, that is the hepatic vein flow velocity reversal, or the forward flow velocity is more than 0.8, then definitely there is a constriction. Then in the cardiac transplantation, here again may not be, all the parameters may not be hold good, only the PRT velocity may be the answer. Now beside this, there are many more new diastolic indications like ventricular strain, strain rate, twist, myocardial deformation measurement, diastolic stress, LV twisting and untwisting, and the LA function. I'll not going into the detail in the basic things because these are the advanced technology, but only one slide before I finish that is most important, that came in the JACE in the last month, in the August 2020. See, you can measure all the LA function without tissue Doppler by only 3 parameters. Take only one zoom view in the apical 4-chamber view. It should not, LA should not be foreshortened, and both in the longitudinal and the transverse view, where you measure the LA max, three measurement only. LA maximum volume, LA volume at end diastole, that is the volume at LV end diastole, that is the maximum volume. Then minimum volume, LA volume at end systole is the maximum volume that we measure actually. Then end diastole is the minimum volume, and another is LA pre-LA volume, that is LA volume at the onset of P wave. See, if the 3 things you can get, you can measure all the 3 important functions of the LA. One is the LA reservoir function, LA conduit function, and LA active contractile function. How? See, LA reservoir function is by LA total emptying time, by LA maximum volume minus LA minimum volume, and then LA expansion index is that LA total emptying volume, that is the difference divided by LA minimum volume. It will give the expansion index. So is the reservoir function. Then conduit function, LA passive emptying volume, that is the LA maximum volume minus LA pre-LA volume. Then that LA mass emptying fraction is that LA passive emptying volume divided by LA maximum volume. And LA conduit volume is the LV stroke volume minus LA total emptying volume. The total LV stroke volume minus LA total emptying volume is the conduit volume. And last is the LA active contractile function that is given by the booster pump of the LA contraction. So what you do, LA active emptying volume is the LA volume pre-A minus LA volume minimum, and that is the LA active emptying volume divided by LA pre-A volume will give the LA active emptying fraction. So this way you can determine only one from single measurement the LA function. Thank you.
Thank you, Dr. Dey. I mean, you have covered almost everything. I was going to ask you about the estimation of the LA function because I thought, I mean, one just last question. Do you think that apart from estimating all these three functions of the LA, what about the peak left atrial strain? I mean, would that be an easier assessment for doing a quick echo?
Yes, yes. Now the LA strain is coming in a very big way, but only you are absolutely correct, because this is a rough estimate. But if you have to really function the particularly in a patient with the atrial fibrillation, when it goes to the sinus rhythm, where the LA is still tunted or having some activities there, LA strain is required. But only problem with the LA strain that we still not have any dedicated software in this type of machines. We probably in the very next advanced machine will get the LA software. That time that will be very easy. What we do is that we are taking the LA circumferential strain in LV circumferential strain into the LA, but that is not exactly giving the LA properly. Or what you do with any of the LV strain, extrapolate into the LA and just joining it, but that is not giving into proper LA strain. When you get the dedicated software in a 3D volume, LS, you find out the LS strain that you would give away. All the three functions in the, you can find out from the strain all the three functions properly, absolutely correct.
The point I was trying to drive home, that LV diastolic heart failure is as much a left atrial disease as it is a left ventricular disease, and often it is more a left atrial disease than a left ventricular disease.
Absolutely.
So
absolutely.
that is something we should keep in mind. Tirthankar and Mr. Snehal, do you have time for questions?
Yes, sir, there is no problem if you want to ask questions or you want to take
yeah, of course. I mean, without question answer any session.
Yeah, we have time.
So,
we have time.
So
one second, Soumitra, can I come in?
Someone read out the questions. Yes.
Just 1 second. You were talking about LA strain. What Aniruddha said is perfectly right, but the newer machines, the high-end version of the Philips as well as GE machines, they have integrated dedicated software for LA strain already. And it's going to come in other machines and maybe in lower versions as well with time. Given the importance of LA strain, the importance LA strain is getting day by day.
Yes, thank you.
Do agree.
Yeah, questions please, because we are getting late. Mr. Snehal?
Actually, sir, there are no questions from the chat box. If anyone from the audience wants to ask the questions,
yeah, you can ask the questions directly.
You can unmute everybody.
Please,
you can unmute everybody.
Anyone please unmute yourself and ask.
Yeah. There is one
and
question
introduce yourself.
Sir, there is one question from Dr. Saurav Agarwal. He says that how not to miss RCA territory infarction in 2D echo.
RCA territory infarct in?
How not to miss RCA territory infarction in 2D echo.
I think this question should go to Dr. Rajat Subro Ghosh because he was dealing with LV structure and function. So Rajat, would you like to answer?
Yes. So basically, we have to look at all the segments that are supplied by the RCA, right coronary artery. Look at the short axis view and look at the inferior basal septum, look at the basal inferior wall, and also look for the right ventricular function. So Dr. has explained how to look for right ventricular systolic dysfunction. So these are the areas that you have to look for. Even in the apical 4-chamber view, you can look at the apical 2-chamber, not 4-chamber, 2-chamber, and you can see the inferior wall on your left side. And in the 4-chamber view, you can see the basal inferior septum, which is supplied with the RCA.
Yeah. Rajat, if I can supplement the question, for a infarct, it is not a problem. Suppose it is a non-STEMI or an unstable angina with a RCA territory involvement. Often you cannot find out with your eyes, I mean, which territory is hypofunctional. How do you think regional strain can be of value?
Yes, regional strain is addressing this issue, but I don't think it is still accepted as a the determinant of segmental wall-motion abnormality or functional abnormality. But it is the technical improvements are going to happen, and possibly we will see regional strain as a marker for ischemic myocardium.
One point I can add. One point I can add here. See, regional strain is not yet standardized and not is accepted by anybody. But what you can do, if you can do the RV free wall strain, that is very important. Even if small, that is what you are talking about. The even not infarct. Even before that, RV free wall strain is definitely increased, not the RV global strain, because that may not be affected because of the strong represented by the LAD. But RCA is affected. Definitely the RV free wall strain will be. You can find even the TAPSE is normal, but RV free wall strain, because I am doing a particular paper nowadays with Dr. Parthasarathy Bhattacharjee. There are a lot of patients is coming with COPD. Even before going to the TAPSE comes, the RV free wall strain is getting decreased. We are getting a lot of RV free wall strain is in the range of 15 to 17, 18%. But global strain is normal, RV global strain normal, and the TAPSE is absolutely normal.
Thank you. Any other questions, Mr. Snehal, or someone from the audience can directly ask any question? Yeah, from Mr. Shashi, MVP in anterior mitral defect, how long? Yeah, please show it again. How long? What is the question? What does it read?
One minute, I'll read it out, sir. MVP in anterior mitral leaflet, how long you advise the patient for follow-up?
Yeah, I don't know who's going to address that. Anyone can address. We are not dealing with valvular heart disease today. We are dealing with normal functions. But anyway, since the question has been asked, anyone? I suppose if I can initiate the answer, if you have a MVP, there is always a chance of chronic deterioration and even acute deterioration, because the subvalvular apparatus is often abnormal. There can be spontaneous chordal rupture and things like that. So if the patient is asymptomatic, maybe at intervals of 2-3 years, but if the patient suddenly develops symptoms, he or she should be assessed SOS. I mean, do you agree? I don't know.
Hey, see, MVP, if it is a mild, suppose mitral valve prolapse with a very mild regurgitation. So it may not be, but mitral valve, so if you have a mitral valve prolapse with a moderate regurgitation, what you are telling is absolutely correct. But if it is a mild regurgitation, I think maybe 1 or 2 years follow-up is enough.
But then remember, MVPs can deteriorate accurately because there can be sudden problems.
Yeah,
of course, after infective endocarditis, and then of course the chordae are very unreliable and very susceptible to rupture. Yes. Okay, so any other questions?
None, sir, till as of now.
So I think the presentations have been so comprehensive and elaborate. I think everyone is going back satisfied. So I think, I mean, I must congratulate all the presenters for a very comprehensive, elaborate presentations. They have literally left no stones unturned in their respective topics. So thank you everyone, and thank you members of the audience, and thank you Torrent team for this maiden endeavor on EcoPulse. So I suppose any comments from my colleagues, anyone with any suggestions or any comments?
So what we can do here is we can plan the next session and announce it to the audience right away.
So we can do it offline. I rather than doing it online, let us do it offline, or
okay.
I mean, we can meet at a later date.
Okay, I don't mind. Yeah.
Yeah. So, Mr. Snehal, your final word from the team of Torrent.
Yes, Dr. Saab, I would request Titho to propose a vote of thanks. Titho.
Thank you, and good evening to all respected doctors. On behalf of entire Torrent Pharma, we take this opportunity to express our sincere gratitude to all of you. Your expertise and suggestions have surely benefited to all the attendees. The valuable inputs and views shared in this webinar has been a great help to all the delegates. We express our heartfelt thanks to Dr. R.S. Ghosh, Dr. Dipankar Datta, and Dr. Aniruddha Dey for today's wonderful CME and for their fantastic elaborate deliberation. Also would like to thank Dr. Soumitra Kumar for moderating today's CME. We're also thankful to all the delegates without whom this CME would not have been successful. So thank you very much for participating in this EcoPearl CME series. Stay safe and good night to all of you. Thank you very much.
All the best and good night.
Thank you, sir.
Thank you.
Thank you, sir.